Hello everybody and welcome to this webinar. Bonjour à toutes et à tous. The webinar title today is Making the Links in Canada and Africa, Evidence-Informed Policies to Improve Maternal and Child Health. The webinar will be taking place in English today with simultaneous translation available in French. Les instructions sont inscrites sur l'écran. Il vous faut utiliser le bouton en bas pour écouter la traduction. I am very happy to be here today with you all. My name is Mélodie Tondeur. My pronouns are she and her, and I'm the manager of metrics at the Canadian Partnership for Women and Children's Health, or CanWatch for short. Thank you very much for joining us today from across Canada and Africa. I'm joining you today from Toronto in Canada, where my home is, and where I am grateful to live and work on the traditional lands of many Indigenous peoples, including the Haudenosaunee, the Wendat, and most recently, the Mississaugas of the Credits people. Close to 150 people registered for the webinar today, and we're so pleased. The webinar is being recorded, and we will post it on CanWatch's website and circulate it to you all after the webinar. A little housekeeping matters with the Zoom features. You will see the chat box that is available at the bottom, and we ask you to let us know if you have any technical difficulties. Si vous avez besoin d'aide pour connecter à la traduction simultanée, veuillez contacter Tina La Rochelle, Technical Support, dans la boîte du chat. Please contact Technical Support Tina in the chat box if you need any help with technical support. And we will also be using the chat box to share key resources throughout the webinar. And those resources that we will share will also be available on our website after the webinar. The Q&A box that you see at the bottom of the screen is available to submit questions, and you may do so anonymously. Please ask questions in the language of your choice. N'hésitez pas à poser vos questions en français et nous les traduirons. Now, onto the agenda for today. Today, we're very happy to be joined by 4 impressive panelists, each playing different roles within the Innovating for Maternal and Child Health in Africa initiative, or the MSHA initiative for short. We have invited 2 important guests who will first give some opening words, and then we will show you a short video on the MSHA initiative, which will then be followed by a panel discussion centered around key questions. You will have an opportunity to ask questions via the Q&A box to each panelist. And finally, the webinar will wrap up with some closing remarks from John Dusabe-Richard, Director of the Global Health Division at IDRC. But before we kick off, we wanted to understand who the audience is today, and we made a poll that should be coming up soon on the screen. And we kindly ask you to answer to the questions, please. We will give you, we have a timer here. I can see the timer. A few more seconds. The responses are coming in. Giving you a few more seconds. Wonderful. So let us see the responses. So we are asking you where you're joining us from today, and we can see that the majority are joining us from Canada. We have some from West Africa, Eastern Africa, Southern Africa, and from Europe. Welcome, everybody. And now we are joined today by, I can see here that we have a majority of researchers, followed by some students, and we also have funders that make up the majority of the audience. And then we have some decision makers, some health management colleagues, and some and then other people coming from other backgrounds. Welcome, everybody. And we asked you if you have ever been involved in the MSHA project, and it's about, close to 45% of you have been involved with MSHA initiative, and some of you will learn about it. So, so this actually transitioned really well with now the kicking off of the webinar. And as I mentioned earlier, we have invited two guests to give some opening words today. We have Eva Slawecki, who is Executive Director of the Canadian Society for International Health and a CanWatch board member. And we have Dominique Charon, who is Vice President of the Programs and Partnership Branch at IDRC. We welcome them both. And now I will be passing the mic to Eva. Thank you for joining us today, Eva. Over to you.
Thank you, Melody. Merci. So as Melody mentioned, I am the Executive Director of the Canadian Society for International Health. I believe a lot of our participants are familiar with this organization, and I'm very proud to serve as a member of the Board of Directors of CanWatch. I am based in Ottawa, which is situated on the unceded traditional Algonquin Anishinaabe territory. I can't just acknowledge the land without also calling attention to the devastation that the Indigenous nations had experienced at the hands of settlers. And we are reminded of this more and more, and most recently with the tragic news of the findings at the residential school at Kamloops. We cannot let this be just another news headline that passes us by. This has to be addressed within the broader context of the legacy of colonization, and as a call to action in moving forward to address such injustices, past and present in Canada and globally. And I feel that the organizations represented here are all doing their part, and I hope that we can have such a meeting in a few years' time where we don't have to acknowledge injustices, but can really just celebrate the traditions and lands that we come from. So I am honored to be representing CanWatch here today. For those of you who are not familiar with CanWatch, it is a membership organization of over 100 non-governmental organizations, academic institutions, health professional associations, and individuals. CanWatch champions Canada's leadership to advance the health and rights of women, adolescents, and children everywhere. That's here in Canada and in communities around the globe. Domestically, CanWatch is working closely with Women and Gender Equality Canada to strengthen the capacity and power of thousands of organizations and grassroots community groups working to advance opportunities for women and other disadvantaged populations such as LGBTQ, Indigenous, and racialized women. Today's event is really quite I'm really looking forward to it. From my role as the Executive Director of CSIH, health systems and policy are really key to our, it's a core element of what we do. And this event focuses on the policy side of MSHA. We will showcase successes from the MSHA initiative on how research findings helped inform policies and practices to improve maternal and child health, sexual and reproductive health and rights in Africa, and to highlight the importance of such initiatives to Canada's global health agenda. One of CanWatch's members, the Cummings School of Medicine at the University of Calgary, represented by the panelist Jen Brenner, is going to be speaking today, and that really ties in nicely with the Canadian and global work being done. The poll results are interesting. I'm happy that about half of the panel, the attendees, are aware of MSHA, and I think that such awareness, a mix of people who know it well and who are new to the MSHA initiative, would really lead to some really interesting discussion. And we welcome questions and comments, and really a frank discussion. So today's webinar will include a short video that introduces MSHA, and yeah, and a lot of scintillating discussion, I expect. So it is now my pleasure to pass the podium or the screen to Dominique Charon, Vice President of the Programs and Partnerships Branch at IDRC. Thank you.
Thank you, Eva. Bonjour tout le monde. Hello, good afternoon, good evening, wherever you may be. And it's a considerable honor for me to join you to celebrate the important work that's taken place with this initiative. Je vous adresse, tout comme Eva, je vous adresse la parole à partir d'Ottawa, au Canada, qui se situe sur le territoire traditionnel et non cédé du peuple algonquin Anishinaabe. Et tout comme Eva a très bien remarqué, les droits et les défis confrontés par les femmes et les enfants et les peuples autochtones au Canada et partout dans le monde sont très présents avec nous cette semaine, avec la découverte d'une tombe commune de 215 enfants sur le terrain d'une ancienne école résidentielle en Colombie-Britannique. The rights struggles, as well as the contributions and accomplishments of Indigenous women in Canada and everywhere, really resonate, I think, with the issues that we'll be talking about today. This webinar, as you now all know, is celebrating the results of this Innovating for Maternal and Child Health in Africa initiative, which was a partnership between the International Development Research Centre that I represent, as well as Global Affairs Canada and the Canadian Institutes of Health Research. This was a joint investment of 36 million to bring research to the fore in an effort to reduce maternal and infant mortality on the continent. And this partnership built on 15 years of collaboration in funding global health research in Canada between these partner agencies that started with the Global Health Research Initiative back in 2001 and spawned many other collaborations that helped bring that Canadian collaboration with African and other researchers from developing regions of the world toward innovation and solutions to these global health challenges. La conception de l'initiative pour l'innovation pour la santé des mères et des enfants d'Afrique s'est faite dans le contexte du mouvement au sein de la communauté internationale dans les années 2013-2014 pour mobiliser l'action pour faire reculer le taux élevé de mortalité maternelle et des enfants en Afrique. La Facilité mondiale pour le financement de la santé maternelle et des enfants a été créée au même moment et il reste une plateforme très importante pour faire avancer le financement de l'action contre ce problème. En 2014, on constatait que presque toutes la mortalité maternelle était prévenable et que un grand nombre de la mortalité des enfants aussi prévenable avec des interventions et des solutions qui étaient déjà connues, mais qui n'étaient pas mises en pratique. Most of these maternal and child deaths were taking place in developing regions and a particularly large proportion in sub-Saharan Africa. And so the initiative, the Innovating for Maternal and Child Health initiative in Africa really came at a key moment to help contribute and propel progress on this problem. And progress has been made. For example, the most recent data cited by the World Health Organization indicates a decrease in maternal mortality ratios in sub-Saharan Africa by 38% relative to 2000. This is a tremendous improvement to the success, but there's still much work to do with the maternal mortality ratio in low-income countries still 40 times higher on average than in high-income countries as of 2017. And increased or new risks are being faced by women and children in fragile contexts such as conflict zones and where they are in situations of displacement internally or as refugees. And of course, we have the pandemic of COVID-19, which has accentuated health inequalities, has had disproportionate impact on women and on people living in poverty everywhere in the world, and has disrupted access and use of essential services, including reproductive and maternal and child health services everywhere, and particularly in lower income settings, country settings. We're very concerned about the setback that the pandemic may have been bringing about, and it's not time to believe that the problem has been fixed. Le CRDI, le Centre de recherche pour le développement international, fait partie des activités et des investissements d'aide internationale du Canada. Et en tant que membre de cette grande famille d'aide internationale, le CRDI est très fier du travail de l'initiative dont on discute aujourd'hui, parce qu'elle a pu mettre en place des solutions locales et avec l'outil qui est la recherche d'implantation, a vraiment travaillé pour s'assurer que les résultats de recherche ont été utilisés par les décideurs et implantés dans les programmes et les investissements des pays. The model that MSHA, the Innovating for Maternal and Child Health initiative, uses bridges this know, knowledge, and do action gap. And it has really been effective in grounding the solutions in that local decision-making context. And this therefore means that the results can be more easily scaled out and will reach many more women and children and be long-lasting. And our new strategy at IDRC, which we launched in February of this year, is looking to accelerate research and innovation to address inequalities, climate change, and close the gaps on the SDGs, including in the areas of maternal and child health, reproductive health and rights, and pandemic and epidemic preparedness. MSHA itself funded 28 Canada-Africa partnered research projects, and you're going to hear much more about that today. This innovative model is really, I think, the key asset that we have, where an African principal investigator working in collaboration with a Canadian researcher, co-principal investigator, and African decision-making co-principal investigator put everything in place so that this implementation research could make a difference. We're particularly impressed to see how that collaboration model really contributed to that real-time uptake of evidence and that scaling of the impact. And you'll hear, no doubt, about some of these examples later today, but for example, in Nigeria, in the Bauchi State Primary Healthcare Development Agency now invests its resources to maintain the Universal Home Visits program that was validated through MSHA research to improve maternal outcomes. So this is just one little example. Today, as we learn from work done across sub-Saharan Africa and in Canada to improve maternal and child health, as well as sexual and reproductive health, let's reflect on how these findings can be made available and used by decision makers and program implementers in communities and in countries for this real uptake and transformation so that the women and children's health can be improved. Les défis que pose la pandémie ont démontré que aujourd'hui, plus même qu'avant, les défis auxquels on fait face et l'importance de la recherche pour les relever doivent avoir une place importante dans la prise de décision de décideurs dans les systèmes de santé dans les pays touchés, dans les pays qui épaulent le plus gros fardeau de problèmes de santé maternelle et des enfants. What can be learned from MSHA to help respond and support health system strengthening, particularly in the context of the pandemic? These are questions that I hope you may address today. And I look forward to the conversation. And before I hand it back to Melody, let me thank and acknowledge the work of IDRC's team on this program, Montasser Kamal and Nafi, who's here, Marie, and many others who have really helped ensure the success of the program. And I'd must also congratulate you, researchers, stakeholders, decision makers, and all of the people from the communities who contributed to the work. Et je remercie aussi de la part des instituts de recherche de santé du Canada et Affaires mondiales Canada. Je vous remercie tous de vous joindre à nous pour cette discussion aujourd'hui. Merci à CanWatch pour la plateforme et puis j'ai très hâte à la très bonne discussion. Merci.
Merci, Dominique. Thank you, Eva, for these opening words. And now, as we mentioned already, I think several times, let us watch a short video on MSHA. So over to you, Imayen, for showing us the video. Thank you.
If you don't improve
Tina and Imayen.
Yes, Melody.
I think that the sound might not be working. Yes.
Okay. Sorry.
One of the main problems in Africa, sub-Saharan Africa, was the high level of maternal mortality and the high level of infant mortality.
if you don't improve maternal and child health and women's health in particular, we're not going to be able to reach the Sustainable Development Goals globally, but we're also undermining a great asset from in the countries.
99% of all maternal deaths occur in developing countries. What that highlights is that maternal deaths is not something that has to happen. It's about being able to make sure that the right services and supports are there for women who are delivering around the world.
MSHA as an initiative arose with support from the Canadian Institutes of Health Research, Global Affairs Canada, and the International Development Research Centre.
I think the great thing about MSHA really is the collaboration of these three Canadian agencies. Each has decades of experience in terms of bringing something specific to this initiative. And so coming together, I think the value proposition of each of these Canadian funders was clear, and the key was designing initiatives that built on each of their expertise.
MSHA was designed for impact. The idea was that there's a lot of interventions out there that are already known how to improve maternal and child health, but that they're not able to be fully implemented and scaled successfully.
What is at the core of this is ensuring that overseas development assistance is both effective and efficient, thus ensuring that money invested goes the farthest.
While MSHA's purpose was to make the evidence work to change the policies and practices within the countries.
The initiative funded 28 research projects in 11 countries in Africa and 2 health policy and research organizations that we call HPROs. These 28 research projects, they are led by 19 research teams. They needed to be composed of 3 core team members.
It has a principal investigator from Africa and a co-principal investigator from Canada, and then a co-principal investigator who is a policymaker, and still a policymaker from Africa.
What impresses me the most about MSHA is how this brings together African and Canadian experts to collaborate to find solutions to some of these tough problems.
They are designing their research project according to country priorities, to their own challenges, and according to their own systems.
Having an African PI It gives more ownership to the local ones.
Mon rôle dans ce projet était vraiment celui d'accompagner mon partenaire nigérien. Et l'idée vraiment, c'est de cette mise en commun-là, de voir comment les expertises des uns peuvent compléter celles des autres.
The piece of the design that is perhaps the most important or the most fundamental to achieving results is the inclusion of an African decision maker within each of the research projects.
By having policy makers in the team, the uptake and the use of evidence has increased. This ensures sustainability of the project even beyond the funding period.
Also in the design, having what we call health policy and research organizations, so what we call HPROs, we have for East Africa and for West Africa. And the role of those organizations is facilitating the translation or the interpretation or the communication about the findings from the research projects to larger groups of decision makers at the regional level, shortening the distance between research and the uptake of the research.
The HPRO, they have been very instrumental to provide various trainings, and it helped as an individual project to meet other teams and learn from each other.
The most important things about MSHA is that it works both with local research teams and it works with regional organizations. The local research teams provide innovations and solutions that are needed in a particular locality, and bringing those teams of researchers together allows a learning from experience elsewhere and allows a cost-effective way of introducing those innovations in other contexts.
Notre plus grand accomplissement aujourd'hui, c'est que l'ensemble des 15 ministres de la Santé, à travers l'Assemblée des ministres de la Santé de la CEDEAO, ait accepté d'adopter la résolution que nous avons présentée pour que l'utilisation des évidences, les standards, les normes et les protocoles soient une réalité. Et c'est grâce au rôle d'OPRS que l'OAS a joué dans le cadre de l'initiative MSHA.
The success of this program resided in a couple of factors. First, there was enough resources to sustain a journey with many teams in many countries in Africa. Second level is with the health service themselves. They were part and privy to these programs. The research team were always integrated in some kind of health service depending of the context where they were operating. The third level is that the decision maker were part of the journey from the beginning. But that would have been nothing if these research teams had not had, the implementation inside and the community, which is fundamentally, the most important thing of all of this. You can do all the capacity you want, but you need also to involve the people that you are targeting for improvement of their health and well-being. That's what, in a nutshell, the initiative has been doing over the years.
I think there's fantastic examples in MSHA of local solutions being adopted. They have made sure that the evidence that's being produced affects and changes public policy to ensure that women and their children are healthier.
So at least 90% of our pregnant women deliver in the hospitals. So they've moved from delivering at home, they're coming to us.
We trained about 10,044 community health workers, as well as more than 100 religious leaders, so that they will teach the community to improve their awareness and promote maternal and child health.
Les Badjanogos ont réussi à faire 10 000 visites à domicile, faire de telle sorte que les femmes en grossesse puissent aller suivre normalement leur grossesse, ce qui posait problème avant.
It helped us to contribute in strengthening health system in our country to save the lives of vulnerable women.
People now trust the facilities, and the women now can deliver in the health facilities. We have seen a significant reduction of maternal death.
L'impact le plus immédiat, c'est que depuis la mise en œuvre de ce projet-là, nous avons enregistré 0 décès maternels. En soi, c'est vraiment un succès incroyable.
When three agencies combine their different abilities, their different skills, their different contexts and expertise, what it shows is that we can actually make a real difference in the world. And we're seeing it with MSHA.
Thank you, Iman, for showing us this video. We hope that you enjoyed it and found it informative. So now we are going to be moving to the panel discussion, and it will be moderated by Nafi Diop, who is Senior Program Specialist at IDRC, and she leads the MSHA initiative. Before we start, we would like to tell you more about our panelists. So we are joined today by four impressive individuals, each playing different roles within the MSHA initiative. We are joined by Dr. Queen Dubé. Dr. Dubé is a passionate consultant, pediatrician, and clinical epidemiologist. She is the Chief of Health Services for Malawi's Ministry of Health. Dr. Dubé also served as the head of pediatrics and child health at Queen Elizabeth Central Hospital, one of the largest tertiary hospitals in Malawi. Dr. Dubé has worked with the Ministry of Health, Saving Newborn Lives, USAID, WHO, IDRC, Pediatrics and Child Health Association of Malawi, and UNICEF to improve the quality of newborn care in district hospitals and to improve the quality of care for the small and sick newborn in Malawi. Welcome, Dr. Dubé. And we also have with us today Christina Zarowski, who is full professor, Department of Social and Preventative Medicine at the School of Public Health, Université de Montréal. She's a researcher in global health at the Centre de Recherche en Santé Publique de l'Université de Montréal et du CIUSS du Centre Sud de Montréal, and extraordinary professor at the School of Public Health of the University of the Western Cape, South Africa. Welcome, Christina. And we also have with us Dr. Jen Brenner, who is pediatrician and clinical associate professor in the Cummings School of Medicine at the University of Calgary. Over the past 2 decades, Jen has engaged in many maternal, newborn, and child health implementation, research, and policy initiative through collaborative university partnership, including in East Africa with the Healthy Child Uganda and Mama Nam Toto Tanzania partnerships. Welcome, Dr. Brenner. And last but not least, we have Mr. Patrick Mujerwa, who is an economist by training with special interest in reproductive health, family planning, population and development. He's currently the program manager for Partners in Population and Development Africa Regional Office. Patrick has over 15 years of experience in designing, implementing, monitoring, and evaluating advocacy programs in the areas of reproductive health, family planning, HIV/AIDS, population and development. Welcome, Patrick. So now I will be passing the mic over to you, Nafi.
Thank you, Melody, very much. So before I start, I would like to acknowledge that I'm joining you today from Ottawa, Canada. And I would like to begin by acknowledging that the land where I live and work is the traditional and ancestral territory of the Algonquin Nation. I would also like to acknowledge that you are joining all of us today from many places, near and far. Since this is a virtual event, I will encourage to think about and acknowledge the traditional owners and caretakers of the land you are on. As said before, note that the discussion for this panel will be in English, but again, there is simultaneous translation. Feel free to ask your questions in English or French. N'hésitez pas à poser vos questions en français. Now, it's my pleasure to moderate this panel that brings together 4 different types of stakeholders involved in the process of from generation of evidence to its use into policies and practice. We have the researcher, the knowledge broker, the decision maker, and another type of users of research findings, the implementer of health programs. We will proceed in a conversation style. I will ask a round of questions to each person, one after the other, and then we'll do another round. So let me start by the decision maker. Queen Dube. In MSHA, we emphasize collaboration between researchers and decision makers. As the decision maker co-principal investigator in your research team, can you explain briefly how you engaged with the MSHA project and how that compared with the previous experiences with researchers?
Thank you, Nafi, and thank you for inviting me to be part and parcel of the panel. So it was really an exciting moment to be involved in the MSHA project. From the conceptualization of the idea to the actual implementation, analysis of the results, and then the thinking through what happens after this. So traditionally what happens is the researcher works in their own silo, the policymaker will be in their own silo, and then you have implementing partners again in their own little silo. What this particular MSHA project, at least for the Malawi side of things, did was to bring everybody together as part and parcel of this continuum of care. Because at the end of the day, we're all targeting the same patient or the same human being. We shouldn't be working in silos. And so it's been a very big learning point. As a policymaker, you cannot do without evidence. And as a researcher, you're useless without the policymaker that can then translate the evidence into policy. As an implementing partner, you're useless if you're not given the policy and the right framework within which to actually implement. So thank you very much.
Thank you very much. Now let's move to the Christina Zarowski. Christina, as the Canadian researcher, co-principal investigator in your research team, can you explain briefly how you engage with the MSHA project and how the team fostered mutual beneficial collaboration between the part of the team that is based in Canada and the part of the team that is based in Uganda and South Sudan?
Yeah, thank you, Nafi, and thank you, colleagues, for this terrific opportunity. And I'd like to begin by acknowledging that Université de Montréal is situated on the unceded territory of the Ganangahaka or Mohawk Nation, historically known as a gathering place for many First Nations. That's a terrific question, Nafi, and I think that just by sheer coincidence or luck, I was just starting a new position at a new university as head of a department at a new school of public health. So when we were contacted by colleagues in Uganda and then South Sudan to join with them on this initiative, which they initiated, I had to say, I'd love to. I'm really busy. You have to be running this show. And I think that that really set the stage for an important process throughout the years. And reflecting on this, there are a number of points that I think that are really important about this. And one of them is acknowledging the expertise and also then the limitations of people. So our research knowledge user partner is Director of Reproductive Health at the National Ministry of Health. He was not available for a weekly Skype call with all of the team. So we had to learn to take advantage of his opportunities and his insights to make sure that that was integrated and vice versa. We had to recognize, and we learned to recognize, the skills and the expertise of our South Sudanese colleagues, of our Ugandan colleagues, and of the Canadian colleagues, and to work at different levels that were driving the process. So when open warfare broke out again in Torrid, our project coordinator in Torrid became the ethnographer and was keeping daily journal records of what's happening and how does this affect health service access and so on. So he becomes the researcher. We included research analysis that was very technical and sophisticated, but also developing approaches and tools and methods where there is no researcher. How do you do qualitative research reasonably if you're not a if you're not an academic to begin with. So I think recognizing the expertise, aligning the reality with the realities, and the flexibility was important. A couple of other things I think were really important. The most important perhaps is building trust. And so the fact that this was initiated by our colleagues in the South and that it built on some existing relationships was critical to the start. And then there was a lot of effort that went into building trust, concurrently with recognizing that conflict and disagreements are inevitable. So it's not a question of everything being lovely all through, but rather of having the trust and the transparency and the relationships to enable those issues to be identified and addressed. This included having our team meetings in South Sudan and Uganda alternately whenever possible. It included identifying different focal points for engaging with the HPRO or IDRC or other decision makers. It included transparency about budgets as well, right from the start, and co-authorship and co-participation in both academic and policy engagement initiatives. So those are some of the elements that I think that meant that we learned a lot, that everyone learned a lot, that people contributed, and that people felt safe to say, this isn't working for me, I've got a problem here.
Thank you, Christina. And again, as we go during the discussion, participants, please feel free to ask your questions in the Q&A box, so we will address them. Now, let me turn to Patrick. Patrick Muguyewa. As a member of the East Africa HPRO that Christina talked about, a health policy and research organization that was part of MSHA, can you explain briefly how you engage with the MSHA research team? How does that compare with your previous experiences of knowledge broker who promotes the use of research evidence in policies and practice?
Thank you, Nafi, and I'm pleased to be part of this meeting. Really, I don't know what else I can add to this. Best if you hear what Queen has already mentioned. I don't know what more I can add, but really to say that as a member of the East Africa Health Policy Research Organization, our role is really mainly to do high-level convening for policymakers. We are an advocacy organization and play that role. We are not a research organization, and yet we have to do advocacy that evidence-based and policymaker-centric. Now, advocacy is really about communicating and dialoguing with policymakers, being strategic, good mobilizers, but most importantly, staying true to evidence and moving evidence to policy action. Now, when you look at all of this, you find our engagement with such teams then has been complementary to each other's roles and mutually beneficial. Mutually beneficial in the sense that as advocates, we needed to have evidence presented to policymakers that we convene to spur advocacy. And on the other hand, research teams needed the policymaker forums where they could have their products disseminated and shared, because researchers are really not necessarily the best experts at convening and linking policy and decision makers. So in this regard, our engagement has really taken different forms, including convening national and regional forums for policymakers and having researchers actively participating by presenting and sharing the products that they have. We have also engaged in linking researchers to decision makers and technical groups in the Ministry of Health to make sure that the research they design is relevant and in line with the priorities of governments. We have also collaborated with researchers to develop knowledge translation products like policy briefs, fact sheets, infographics, and what have you. And also important has been to support researchers to develop smart messages that make a compelling case for evidence utilization and decision making. Sometimes you find researchers are really so abstract and they may not have that skill of crafting messages that talk to the decision makers, and so have been instrumental in collaborating in this regard. And last but not least, indeed, we've also been contributing and working closely with researchers to making sure that we document some success stories that have occurred here and there. So, and then in terms of how I compare this with the past experiences, I can say that initially Previously, we would invite resource persons to present at policymaker forums on existing evidence, lessons, and good practices that would inform policy action and decision making. But in a majority of cases, that evidence will not be very well appreciated. It sometimes would be contested because policymakers were not involved in research design, in the research methodologies, and other processes, and therefore it would be difficult for them to appreciate such evidence. But the difference now is that we link researchers, the policymakers, and create spaces for policymakers to engage researchers and making sure that they get involved in all the processes. And in this regard, they have a fair appreciation of the evidence that is presented. And this has really increased uptake and its utilization for policy action. Thank you.
Thank you. Last but not least for this round, Jen Brenner. Jen, you wear several hats. You are a seasoned global health researcher, you teach, you practice medicine in Calgary, and more. Also, you receive funding from Global Affairs Canada as a Canadian lead on a Canadian-Ugandan partnership. And you are the Canadian research co-principal investigator on the MSHA project. Today, however, you are wearing principally the hat of the Canadian lead on that implementing partnership with Uganda. Can you tell us briefly about this partnership and how you are using the findings from your MSHA grants in the new implementation project you are starting?
Yeah, sure. Thank you, Nafi. As I begin, I'm actually taking this call from a beautiful place, which is located on the traditional territory of the Shuswap First Nations, and namely adjacent to current lands of the Kiskonuk Band. And it's a beautiful spot and a thoughtful place. Yeah, I feel quite privileged to have been able to play various different roles and have the perspective from both the research side, the implementation side, and then somewhere in between. And the current partnership, which is about to initiate a really new, exciting project that I'm working with, is a partnership called Healthy Child Uganda, which has been around for quite some time. It's a partnership between the University of Calgary and other Canadian universities with incredible partners in Uganda through Mbarara University of Science and Technology and the adjacent communities in rural Southwest Uganda. The Canadian Pediatric Societies also played a big role in this partnership. And so we've been fortunate over 2 decades to work together. Now, we've over time been developing programs in maternal child health programming and doing both research and implementation and evaluation. And we've learned many lessons related to particularly scale up of programming at the district level involving community-based or community health workers. And about 5 years ago, we were fortunate to have the MSHA experience of scaling up our lessons from Uganda in an implementation experience accompanied by research in Tanzania and Mwanza with our partners at the Catholic University of Health and Allied Sciences. Now, that partnership learned many lessons about programming and scale up, and we were able to package a package of materials that were evidence informed as a result of the MSHA experience. And now we're in an exciting position of taking those experiences back and this package that's informed by the MSHA research to Uganda again. So we have an implementation that's about to start in the area of adolescent health and sexual reproductive health and rights, which is a very high priority area in Uganda. So what we've been able to do, which is kind of exciting, is see now how we're going to implement this package and also continue to work in a south to south partnership as well between the Ugandan team and Tanzanian colleagues, and share learnings both from the research and then specifically into the implementation side. So we're really excited that we've been able to create this new package from the MSHA experience really tie up a lot of the pieces and inform best practices that will now be applying to for us, a new area of adolescent health and wellness.
Thank you. So that was the first round to more or less introduce what you're doing, what is linked to MSHA, and how decades different with your different hats on this panel. Let's go to the second round now. And again, I'll start with Queen Dubé, the decision maker. Queen Dubé, decision makers sometimes argue that research takes too much time, while they need to take action here and there. What would you tell them, those decision makers, to champion the use of research evidence in making decisions for policies and practice?
Thank you, Nafi, and greetings from Blantyre, Malawi. It's a question that we tend to get now and again. And my simple reflection is, what is easier? To do things the right way, or to spend 10 years doing things the wrong way? You waste resources in terms of money, everybody's time. And when we're talking about the health sector, their lives also. So we're not just talking just about survival, but also morbidity associated. If you want a good thing, you must be willing to pay for it. And actually, when you look at the African context, we don't have a shortage of policies. The gap that we have is on how we implement the policies and the strategies that we have. And that's why investing in implementation research is really critical. And once you realize as a policymaker that I am part and parcel of this continuum, I'm part and parcel of this amazing puzzle. This puzzle won't be complete if this important piece is not there. And that's the policymaker, the researcher, the implementing partners, and also the communities that we're serving. And so simply put, it is actually not waste of time. It is actually good use of time. What we need to be discussing is what research is useful to a policymaker. Because some of these research, very high level, and a researcher might not see the immediate need now. So truth be told, a researcher won't be very much excited with very high technical research that is looking at a particular sequencing pattern of some rare virus of some kind. But look at COVID. It's hit the globe left and right. And it's taught us that policy is useless without the evidence. We've moved really fast in terms of prevention, in terms of actually making the diagnosis, and also the vaccine. And how did we get to where we are today? It was because it was the right question for the policymaker. It was the right question for the communities out there. It was the right question for the researcher, people in academia. We need to figure out this niche that is right for everybody else. So this question around, oh, it takes too much time. No, we're there to implement and see that our policies are actually giving us the impact that is desired. So it's not a question about time. It is the question should be, what type of research should we be propagating in our context, particularly in the African region? And I like this implementation research agenda because it quickly answers to the policy questions. You implement as you go along. You're not waiting for 4 or 5 years when then there's this big research dissemination conference and you invite 400, 500 people. Then there'll be a series of more meetings. How do we go about this? The MSHA approach allowed us within the first year, tackle certain things, change some of the elements within our strategy documents and move on. And that's what we should be encouraging our researchers to look at. Thank you.
Thank you. Now, talking about researcher, let me ask a question to Christina. Christina, there were emerging researchers in your project. some based in Canada and some based in Africa. How do you think MSHA benefited these emerging researchers who are entering the field of global health, especially in these interesting times?
Okay. Thank you very much. That's a fantastic question, and I love what Queen Dubé just said about that. There's a whole range of ways that the emerging researchers and the participants have benefited from this. Right from the beginning, we thought, well, let's train people to do an MPH and a master's in implementation research. Our South Sudanese colleagues reminded us after 30 years of civil war, they have almost no midwives trained in the country. So IDRC or MSHA was flexible enough to say, okay, let's train eight midwives. So that's already how to think rigorously and systematically. Within the team as well, we wanted our field workers, our supervisors, the women's group to become researchers in the sense of being able to reflect systematically and critically in what they were doing so that they could use their own information and apply it to solve their own problems. On the research side per se, it was a terrific opportunity for our Ugandan, South Sudanese, and Canadian colleagues at various stages of their emerging careers to gain skills, to publish, to present, to exchange with people at conferences like the Health Systems Global Research Symposia, the Canadian Conference of Global Health, other events. I don't want to make it sound all sweetness and light though, because the reality is that for Canadian researchers, working on this kind of a program is much slower and much more difficult than conventional. So it delays a career path. It's not easy to publish quickly if you're trying to be equitable and participatory. So how do we address that as institutions and as research funders? For our colleagues at Lachor Hospital and in South Sudan, we had plans and money to support PhD training that would have been fantastic. And in the end didn't happen. Why? Because the capacity is so thin on the ground, and the people who would do the PhD are the same ones who are running the ethics committee, the HIV ward, and then the COVID wards, and without a lot of relève. There are very few women who are trained and able to go further in the context that we're working in. So the same ones are constantly overloaded. So I think that there's tremendous opportunities, and part of the benefit of MSHA has been to identify what some of the challenges are and to start thinking about how do we change those incentive systems so that we can continue to build the capacities. But when we were looking at our final report and the publications and the presentations and the tools and the radio clips and so on, it was remarkable, and delighted to have had the opportunity to share this with the emerging researchers in our team.
Thank you. Patrick, your primary constituencies, the primary constituencies of your organization, Partners in Population and Development, who is part of the consortium of the East Africa HPRO, your constituencies are primarily parliamentarian from 16 member countries and 12 associated member states in Africa. How do you successfully engage with such a diverse group of policymakers to champion the use of research evidence in policy and practice?
Thank you, Nafi, for that question, and also that compliment for us to note that out there are people who appreciate that we have been successful in bringing together policymakers to champion the use of research evidence in policy processes. I should also mention that actually our constituency of policy makers who are parliamentarians is Africa-wide and goes beyond the 16 member countries. But maybe to mention that the 16 member countries are indeed members of PPD, but we also have 12 associated members, like we pointed out, who are actively engaged in the processes that we engage. Part of the successes goes back to the reason why PPD was formed. PPD was established to expand and strengthen South-South collaboration between and among developing countries in the field of public health, population and development, and the context of implementation of the ICPD program of action. And therefore, in this regard, we provide platforms where evidence is presented, commitments developed, good and relative practices and accountability for maternal and children's programs is shared. And in a majority of cases, you find that many of these countries you engage are enjoined by common interests and overlapping objectives because they are signatories to a number of global and regional commitments for which they have provided accountability because they were signed by their respective countries. So they see value in engaging with us because they think, because they take interest in knowing how their peers in other countries have fared, have performed, and what potential good practices they can adopt to implement their commitments better. But having said that, of course, our strengths also rise in the high-level political support and convening role that we enjoy among our member countries. We work with the ministers who represent their countries on the board of PPD. We also have partner country coordinators who are director-level government officials who enable us to reach out and make connections with a wide range of audiences, including parliamentarians, technocrats, civil society, who are instrumental in addressing the issues that we're advocating around. But also work with regional networks, like a network of parliamentarians who sit on the committees of health that we have been doing since 2008. And actually the main objective of these networks is to making sure that you bring the parliamentarians together to share good and effective practices around providing leadership and stewardship for implementation of commitments. So I think that's the value they see in us, and that's how I've been successful. But having said that, Nafi, our experience and credibility in developing plans with regional parliamentarians, engaging governments, civil society, and private sector in commitments making and accountability, facilitating networking with other regional players, brokering technical assistance to countries, and convening country parliamentarians champions for advocacy, accountability, collaborative learning, have really endeared us to working successfully with a diverse group of policymakers to champion the use of research in policy and practice. Thank you.
Thank you. Again, Jen, last but not least, what practices are you incorporating into your new project to promote better uptake of research evidence, and how could other non-governmental organizations, civil society organizations benefit from your experience to productively uptake research evidence in their implementation projects?
Yeah, thanks. I think if CSOs, NGOs are serious about their interest in uptake of evidence and research and using, I guess I'd call it evidence-informed practices, then we really need to be making an investment to spend the time to take that, what is known in the research, and at the beginning of a project or at the beginning of a program, work with all stakeholders to make that shift in what we know or what's been sort of proven in the research setting into a real life scenario. And depending how well the researchers have started that process, it may be easier, it may be difficult, but there needs to be a serious investment at the beginning of an initiative to be able to make that research relevant for implementation. So for our project, we really thought hard about the principles of how does the intervention need to be adapted? How is that adaptation relevant for the communities that are about to have this intervention or undergo this intervention together? And how well does the community understand that intervention, and the people who are implementing understand and appreciate why they might be making a shift in their practice? And as Queen Dubé mentioned, we have to bring policymakers in at the very beginning and make sure that these practices really align with what the realities are on the ground. So for our project, the first almost a full year of a project, which is a little bit unusual, and we're grateful for Global Affairs enabling us to spend the time to do this. We really spent the time to take our practices from MSHA, package them well into a format that the community will and implementers will understand, work with the Ministry of Health, work with our district colleagues to make sure that people understand that we can make adjustments to the research practices and best practices we've learned, and then orient people before we start. So an example is we took a very complex model that we had developed after MSHA, and we made it into a visual of a tree, a fruit tree, and we put the outcomes as the fruits, and there's roots and there's trunks and things that need to sustain this tree. And so that's now a more simple packaging of a very complex idea. We have spent time and invested a lot of resources into doing a baseline study, and particularly in the context of COVID, really thinking through how the research that we learned from in Tanzania is now going to inform our practices in Uganda. And we've invested time and resources into meeting with Ministry of Health personnel and trying to understand how a program and research that was developed and, you know, somewhat in Uganda, but also lessons learned from Tanzania, how that can fit with the current policy context. So I really relate to what Dr. Dubé was saying about really needing to make sure there's alignment there with government policy and actual guidelines, which are great guidelines. And then finally, we are also investing heavily in orienting our staff, our implementers, the local health providers we'll be working with at all levels so that everybody understands and has a chance to comment on the research findings and understand and appreciate whether they actually relate to the setting that we're working in. So all of that happens before any implementation starts. And I think for us, that's the way that we think will be more successful with using an evidence-informed package going forward.
Thank you, Jen. So thank you very much for this lively round of question answer discussion, I'll call it. Let's go now to see if there are questions in the Q&A. The first question I see is actually for Queen, and it says, it's in French, so I will read it in French. Bonjour, qui peut-on inclure dans le terme décideur? Le directeur d'un département au sein d'un ministère de la Santé en est-il un? Une telle position permet-elle de mettre en œuvre les résultats issus de la recherche? Queen.
Thank you very much, Nafi. My understanding of French is very, very, very little. At least I can say merci beaucoup. So who is the decision maker? Each one of us, in one way or the other, we are decision makers. But in as far as government policies are concerned, you have decision makers at the national level, regional level, district level, but you can even go down to a facility level. So government uses different systems where you have a decentralized system like in Malawi. Then at a district level, it is also very, very, very critical because they are decision makers at the level of the district council. But in terms of national policies and strategies, those are crafted at a national level. And one thing that I also need to mention is that traditionally we've thought in as far as health is concerned, then we're talking about, senior people within the Ministry of Health. No, you need to get people within the ministers of gender involved. So if you're talking about adolescent health issues, you cannot just tackle them as just Minister of Health. You need to get the policymakers within the Ministry of Education involved, gender involved, and so forth and so forth. And that's one of the things that our researchers need to understand within the health sector, because they're always thinking, oh, should I just involve the Chief of Health Services or the Secretary for Health? No, maybe the right policymaker to involve is this person within the Ministry of Education. Or maybe you don't even need somebody at the national level, you need somebody at the sub-county or county level. So we also need to move from this notion whereby policymaker equals the Minister of Health or the director. We need to look at all these levels way down to that health center. Thank you very much.
Thank you. One question that is asked to all of you. Thank you, panelists, for a very rich discussion. If you had to give one do and one don't advise to other decision makers / researchers / knowledge brokers or evidence users for effective uptake of research evidence into policies and practice? How will that be? What will those be? So we'll go the same order we start. Let's go the reverse order as we started. We start with Jen this time. Jen, go ahead. We don't have too much time, so please be very brief in your response this time. Thank you.
Sure, thanks. I think I say don't. If you're a researcher and you're about to plan or undertake a research initiative, don't forget to think from the very start about the future scalability or uptake of what you're doing in a real life setting. So always think ahead to think down the road, if the research I'm doing was to be used by someone else in a real life setting with the real life barriers that are there, cost, practicality of doing an implementation in a rural setting, the types of resources, human resources, et cetera, needed to carry it out, alignment with policy and what's the reality on the ground. Would this research work? And so I would say that's like, that is don't forget about that when you're planning your research, and think, if I wanted to make this 100 times as big as it is, would it be feasible? And then what I would say for a do is do invest in the relationship between researchers and implementers. Really spend the time at frequent intervals to hear from each other. Don't forget that implementers actually have a lot of expertise around research, and researchers in lots of cases have implementation expertise. So the groups are not completely separate, and I think we need to invest in those partnerships, and they need to be ongoing, and the feedback needs to be regular. There needs to be a place if people have questions or comments, things are going well, aren't going well, those need to take priority over the research, over the implementation. So the communication needs to happen and the research needs to be relevant from the start. Those would be my do's and my don'ts.
Thank you. Patrick, your turn. What will be your do's and don'ts advice?
Thank you, Nafi. It looks like I'm only adding to what Jenny has said, and maybe that shows how important it is. Really, it shows that if I'm to advise the knowledge brokers alike, they need to provide space for researchers to interact with policymakers, decision makers in the government, to be able to have researchers that are relevant, valid, and in line with government priorities. They needed to know how evidence is generated. They needed to know how questions were formulated. They needed to know how the methodologies were developed, so that they have a deeper appreciation and understanding, and therefore eager to contribute to the research uptake. Active participation in the whole process is really very good, and we've seen it being important in terms of increasing uptake.
Thank you. Now, Christina, quickly, we're really running out of time. Okay. So not that they always were too long, but we expect to have the most.
Yeah, so I think that there's different kinds of research. If you're a molecular biologist trying to develop a PCR vaccine, then that's a different dynamic. But in the world that we're working in, my don't would be for researchers: don't come in as the expert. Don't come in as I'm going to fill the empty heads of these decision makers with my great knowledge. So don't lord it over. Don't be the neo-colonial, I've got all the answers and all the power. On the flip side, the do, I guess I would refer ourselves to the Canadian Coalition for Global Health Research Principles for Global Health Partnership. Those are CIHR has identified those, and IDRC as well. We can perhaps get them in the chat. That puts equity at the heart of what we're doing as researchers and as collaborators, and it identifies elements like authentic partnership, inclusion, shared benefits, commitment to the future, responsiveness to the underlying causes of issues, and humility. So who am I in this position? What do I know? What does somebody else know? And that sort of package can help us to take the time to build true, meaningful collaborations in research and between research and practice.
Thank you, Queen. Your turn.
Thank you. Always difficult to be the last one. Two things really, don'ts. So for us policymakers, let's not close the door to researchers. Let's create platforms where the researchers also feel welcome. What do I mean? So countries, we have existing technical working groups, steering committees, task force that are pushing agendas in terms of policy development, but also the implementation agenda. It's really critical to get these researchers in these technical working groups. There is no policy in the 21st century that you develop without evidence. So actually, even this term that we're saying some are policymakers, even the researchers are policymakers because they're providing the evidence for us to craft the policy on. It's just that we are on the opposite ends of the spectrum, but we're doing the same thing. That's crafting policy and bringing the evidence into action. So open doors for your researchers. Don't be afraid of the academia. They're part and parcel of policymakers. I kind of combined the do's and the don'ts. Do's that I wanted to clearly outline: have a clear research agenda within your Ministry of Health, national research agenda, and this should be made available to the academia. Have a system that tracks your research agenda, not just the research questions, but also the translation of the science into policy and implementation. Thank you.
Thank you. So one very last question, because we're running out of time. We have one more question that I know there are more questions in the chat, but I think we'll stop to that one. It's coming from Emmanuel Ochola, and the question is, and I asked it only to the Queen by question of time. That's the role. What are decision makers? You have a lot of questions. The question is, we saw opportunities for policymakers to obtain evidence from non-university institutions that could research and give evidence. Could it be possible that policymakers are looking for evidence mainly from universities and overlooking other potentials?
I mean, when you look at that particular question, he could be right. Just because universities have a tendency where they have research dissemination conferences, and there's other smaller entities like NGOs that are continually doing this implementation side of research, they don't have these structured research dissemination conferences. So what I would actually advise, and if there are other policymakers that have joined this particular webinar, is get that platform going, where all researchers, whether it's from mainstream academia or from NGOs or other implementing partners, are able to have a conversation on one round table, whether it's on a quarterly basis. Then you are on track of who is doing what. The challenge that we have is this coordination mechanism that brings everybody doing research in maternal and child health together on one table, regardless of whether you're coming from the academia or from an NGO, as I said. And that's an issue that us as policymakers must sort out. Otherwise, there's a lot of duplication. You wonder, in one district, 2-3 different groups are doing research on the same topic, targeting the same individuals. Waste of resources and everybody's time. Thank you.
Perfect, thank you. So one very, very last question, I believe. Which one will I do? I know there are a lot of questions. I think the one that comes right there on the list that I have in the Q&A. And the question is for Christina. From your experience as a researcher, what would be considered your #1 challenge for using research evidence into policy and program and policy and practice?
I think probably the #1 challenge is the is the lack of awareness or understanding or acceptance of different interests. I mean, researchers sometimes think that the only thing that a decision maker has to bear in mind is what is the epidemiology telling me, and vice versa. So I think that there's the main gap is to be able to hear and listen to what is actually at stake for the decision maker, what is actually at stake for the researcher. So that helps us to interpret and to read the data, and also to tailor our messages so that we're not saying, as we've heard it said sometimes, that epidemiologists have to dumb things down for government. No, it's not dumbing it down. It's telling it in a way that your primary audience can understand. So how do we get across that barrier, to me, is the number one.
Thank you very much. I know there are a lot of more questions, and more we talk, more questions come in, but unfortunately we have to stop there. Thank you very much then for that very lively discussion, and thank you for the participants for the questions. I think some questions and maybe some answers maybe in the Q&A or the chat, so please go look at that. And I'm turning back the mic to Melody. Thank you again, everybody, for this very interesting panel. Melody, the floor is yours.
Thank you very much, and thank you everybody for your questions. We will be sharing a slide at the end of the webinar where you can see the contact emails, and we can make sure to reply to some of you that shared your contact with us with your questions. So now we are happy to welcome John Duzabe-Richards, Director of the Global Health Division at IDRC. He will be giving some closing remarks. Over to you, John.
Hello, everyone. Can you see me?
We cannot see you, John.
Yes.
But we can hear you. So we can hear you. So it's great.
Okay, excellent. Because I think my video stopped working. It's on anyway. So when the system decides that you should see me, it will probably put me on. Okay. Good morning and good afternoon and good evening, everyone. It has been my absolute pleasure to be part of today's event. IMCHA's achievements we have seen and heard today illustrate the Global Health Division mandate at IDRC to support implementation research and innovations to strengthen health systems and policies so they can deliver better maternal and child health, improve sexual and reproductive health and rights for women and girls, to be more effective and equitable in preparedness and response to epidemics and pandemics. All these remain our strong objectives and have been resoundingly demonstrated in IMCHA's partnerships, networks, and outcomes. As most of you know, we engage with and support linkages between researchers and decision makers to foster greater uptake of research findings into policy and practice in low and middle income countries. We believe that research evidence is key to documenting and intentionally addressing structural inequalities, such as those that put women and girls' health in harm's way. Today, we have reflected on the connections, collaborations, and knowledge transfer strategies that contribute to translating research evidence into policies and practices for better child, maternal, sexual, and reproductive health outcomes. I hope that this event has informed clearly on the good practices used by IMCHA. I hope that this event has quenched your thirst to know the lessons we have learned on how to bridge the knowledge, practice, and policy gaps. As we have heard, the IMCHA model was very much focused on this from the start, on ensuring that research evidence is co-delivered and reaches influential stakeholders to inform programs and policies. This was achieved by deliberately embedding decision makers into the core research teams. IMCHA's innovative design benefited from experiences of excellent previous initiatives, including several IDRC partnerships with Global Affairs Canada and the Canadian Institutes of Health Research. It benefited from the dedication and expertise of former and current colleagues. But of course, MSHA would not have been such a success without the exceptional work of all the researchers, decision makers, and knowledge brokers that contributed to this body of knowledge and whose efforts resulted in it being translated into action. I have no doubt that the important lessons gained will inform future work to further our goal of a better maternal, newborn, adolescent, and child health around the world, and in particular for vulnerable populations. At IDRC, we will continue today's conversation with you and with all the stakeholders. MSHA will leave a legacy of many products to facilitate additional discussions and future successes. Please put these products to good use. Now, I would like to take this opportunity on behalf of IDRC to thank you all for this wonderful collaboration, to thank everyone who contributed in one way or another to MSHA's success. A special thank you to MSHA team at IDRC for a job well done. And thank you all for attending and participating in this important discussion. Merci et grand merci.
Thank you, John, for these closing remarks. And now my colleague Imain will share on the screen the contact details. Thank you to all participants. Thank you to the speakers for sharing your important work on MSHA initiative. So you will all be receiving in your inbox the webinar summary, the recording, and all the resources. I thank you all very much for coming again today. Goodbye, everybody.